Record. Perfect. Everybody, welcome. People are still joining the meeting. Don't worry. This meeting is being recorded. So if you miss anything, I'm going to be sending out the recording and you guys can, pick up any gold nuggets that you missed. We are on with Michael Cowen and Chad Wooters of Awaken2Sleep. Thank you guys for being here. Very, very excited for what you guys are going to be teaching tonight. We're going to be talking about workflow secrets, creating a blueprint for success with your sleep workflow. It's one of the most foundational aspects of dental sleep medicine. In order to be successful, these guys are going to absolutely kill it tonight. At the end, we will allow 5 to 10 minutes, depending on how many questions there are, for a Q&A time. And I encourage you guys, grab a notepad, take notes, and write down those questions so you don't forget, because they will be covering a lot of material tonight. And if you haven't already seen it, when you close Zoom, you should be redirected to a URL where you can fill out a survey and submit for the 1 CE credit that is available for attending this webinar. Is that all correct, Michael?
Yeah, on the CE link, guys, we'll also post it in the chat. Okay. So as you know, you got to stick around for the CE. So let's hang out.
You got to actually learn something.
Actually learn something. You said I'm going to kill it. Hopefully I don't kill any of the people that are on here with boredom. So
I've seen your content. You guys, I wouldn't have allowed you on here if I didn't know you guys delivered. So
appreciate that, man.
So yeah, I will let you take it away. And like I mentioned, everybody, if you have questions at the end, be sure and jot those down so that we can address all those questions and get those answered for you. So Michael, go ahead and take it away, and I might pop in here and there with questions throughout, if that's okay.
Yeah, please do. Please awesome. Do. I will just as an opener, guys, and to respond to what Todd said. I'm here to answer your questions. If we're going through workflow and my desire is to answer those questions, you got to ask them. So I'll make room for them. Please, if you would, I'm going to give you a little bit of direction. If you'd put your questions that you want answered in the Q&A section, that will give us a chance to kind of matriculate those throughout the time. Todd, you're welcome to hop in throughout. If you see the content go in a direction that the questions are there, please hop in. But guys, if you can reserve, guys and gals on here, if you can reserve the chat for answering my questions, I'm going to ask you a bunch of questions, because there's no sleeping in sleep training and I can't see your faces or throw a Sharpie at you. So that's the best thing I got, is I'm going to ask you questions. I'm going to ask that you'd put those answers in the chat as much as you can. Put your questions in the Q&A and answers in the chat. All right. So quick, just real fast, the disclosures that we got to do. This is a CE event. You're going to get 1 AGD PACE credit for hanging out. You got to hang out for the full hour. We're going to hopefully have some fun. If you don't, I apologize, but I'm going to do my best for you. Also, I am the founder and CEO, like the title slide said, of Awaken2Sleep. That means we're a for-profit company that helps teach dentists how to do this better in their office. My goal tonight is not to sell you something. It's really to help you with your workflow. Hopefully give you a couple of nuggets that you all can take and go help your folks in your practice. That being said, let's get cracking.
Let's do it.
All right, so my background, partly why Todd invited me, but major things that are important to me. I've been in sleep, not asleep, for almost 2 decades. That doesn't mean I was in a coma, but I do know a whole lot about sleep medicine. If you want to talk about that, we can talk for a very long time. Anything else, it's a continental shelf as far as sleep medicine, and then that's it. Husband to 1, father to 4+. I say that because I live in California, the land of, dollars are smaller and everything costs more. So when you have 4 or more children, it's people look at you like you're nuts. The plus is we are a foster family, and I have a 5th child named Sadie Mae, and she's a black Labradoodle. She does actually steal the children's seats in the cars. The other parts that are crucially important, it's really hard to be a student and learn from you all when you don't respond. So again, I am going to ask you a bunch of questions. I fully intend to learn something from you. Yes, Tony, even you, please bring those comments, bring those questions. My why. How many of you guys, if you want to raise your hand or just put yes or no in the chat, that's fine either way. How many of you guys have read Simon Sinek's book, Start With Why? Yes, no's in the chat or raise your hand. Okay, cool. We got a couple yeses. If you haven't watched the TED Talk, it's 16 minutes. It'll take you less time than reading it. Reading it's good. The TED Talk is still solid. Basically talks about, as humans, we got to start with what's most core to us, which is why we do something. And I'm going to pause on the workflow stuff and share with you my personal journey with this, because I think it's going to matter when we talk about workflow and details and passion about certain aspects of your program. You see, like Todd shared, I've been in sleep for a long time. Almost 20 years ago, I started off as a pediatric sleep technician in Loma Linda Children's Hospital in Southern California. That means that I actually had 2 years of sleep training in a 3-month program. That was absolutely ridiculous. We survived 12-hour days, 4 hours of homework. That was unpaid, surprisingly, but they took us, they bought the curriculum from a 2-year college, and there were only 2 schools in the entire state of California that graduated sleep techs, and they put 5 of us through this training. So exiting that 90-day probation period, I had to pass a written and patient-centric physical clinical test. And then once I did that, I got to work with preemie babies, inpatient toddlers, all the way up through adults that were coming into our outpatient clinic. So I had a chance to see a lot of folks. The one thing I didn't expect, several years into that journey of being a tech and doing sleep medicine and building sleep centers, was what happened with my oldest daughter, Anna. She's the one in the teal sweatshirt. Matthew was the perfect baby. He came home and started sleeping through the night at 4 days old. I know. I wondered why everybody didn't have a TV show and 19 children. And then we had Anna, and we knew why. Anna got home and she never stopped screaming day and night, night and day. She'd sleep, she'd cry in a muted tone. She had chronic ear infections, 13 rounds of antibiotics, 2 eardrums perforated. It was bad. She had colic from the meds that were trying to control her reflux. The reflux kept causing the ear infections. It was a cyclical nightmare. And then one Saturday afternoon, I heard something I hadn't heard in 5 months. And it was total silence in our house. My wife and I were playing with Matthew in our living room that Saturday. Anna was in her bedroom sleeping. And as I shared, there was constant noise, constant crying, whimpering, just always noise. And so I immediately walked into her room and I looked at my little girl laying on her back, how the doctors tell you to put your kids, laying on her back, and she does this. And as she lifted her hands, I realized that her fingertips were blue and her lips were blue. And I picked her up. She started crying after gasping for air. I picked her up, comforted her. She fell back asleep in my arms and did the exact same thing. You guys, I got to tell you, there is not to date been a moment that I felt more helpless than that moment, holding my daughter while she's turning blue in my arms, realizing that what she has, not knowing until I saw it with my own eyes, but realizing that what she had was obstructive sleep apnea. I knew that if I take my little girl to the hospital right now, to the ER or urgent care, they're going to do nothing for her because this is a chronic condition. It's not acute. They're not going to do anything overnight. They're going to put her in queue for a sleep study. So we called the pediatrician and we got an appointment Monday and we got a stat referral to get her into the same sleep center I was trained at. And it was going to take 4.5 months to get in. That wasn't going to happen because she wouldn't be here in 4.5 months. She's already turning blue. It's getting worse. So we did what anybody would do. Called in every favor. I ended up helping a tech do their first ever infant sleep study at the same time that we coordinated a pH probe study to measure her acid reflux, and did that in an outpatient setting that hadn't been done on a baby her age before. and it worked. A week and a half later, we got results. She was severe obstructive sleep apneic. Her O2 sats were in the low 80s. And the doctor, Dr. Roy Smith, I will never forget, he looked at my wife and I sitting in that exam room with Anna, and he said, it's because you guys knew about this that she's alive today. I really seriously doubt that she would have made it another 4.5 months. Holy junk. That was a lightning rod. That's my personal story. Look at that girl. She's here in our family. She's alive and healthy today. No reflux, no apnea. She's 14 going on 25. Guys, I got to tell you, if I had a different outcome, like friends of mine have had, colleagues have had, family members, and she wasn't in that picture, I couldn't tell you that story today. Because that's home team. We all have our own version of home team. We have people in our family, in our immediate family, maybe extended family. You have work family that you deal with. We got our own little concentric circles of home team all over. And those folks matter. And at the end of every single failed conversation that we have, at the end of every single broken workflow that we have in the practice is still a hurting patient. My Anna matters more to me than any of you, but your folks are going to matter most to you. So my goal today is really to take the nuts and bolts and the details and hopefully some nuggets that you all maybe haven't thought of before and just remove the obstacles. Let's get that junk out of the way so we can help people. Are you going to treat everybody with an oral appliance? Absolutely not. You shouldn't. Is everybody going to come to you failing a CPAP? No, but some will. There's all kinds of options for patients, and we need to just be the signpost, be an advocate. Let's reduce and remove those barriers, and let's get cranking. That's my goal here tonight. So there's my disclaimer. If I get a little rowdy, it's because of that cute girl in the teal sweatshirt, because she matters, and so do your people. All right. Thanks for going with me on the journey. All right, quick recap. You all should know this. If you don't, I'd be happy to send you an email with any one of these links that you need. All right, you can ask Todd, happy to send them. The ADA in 2017 said you should be doing this. In all general dentistry practices, you should be screening for airway issues and working with your medical colleagues. The American Academy of Dental Sleep Medicine also agreed with the American Academy of Sleep Medicine in 2015 with their guidelines that say oral appliance should be a first line of therapy for all mild and moderate patients. The ADSM in COVID tried to do their job and get it approved for severe cases as first line treatment as well. That has not gone through yet on the medical side. So don't argue with your sleep physicians if they're writing for us a CPAP recommendation on a severe case. But this is where it is today. Maybe it changes in the future. I hope it does. But that's what we got. Also, you all should know what apnea is, what hypopnea is, that they're at minimum of 10 seconds and why that matters. You should also know that AHI is not just a great tasting fish. It's the magic sleep number that everybody remembers from their sleep study, if they remember anything at all. RDI is your respiratory disturbance index. You just add your rares into the AHI and that's your number. You all should also know that nasal breathing is how we want to breathe naturally. When we can't, we don't. A lot of times that's because of OSA. So obstructive sleep apnea predominantly occurs in the posterior hypopharynx, blocking the oral airway because of the base of the tongue. You move the lower jaw forward, makes sense that it's going to pull the tongue with it, open up the back of that airway. This is stuff that you guys should know. Mild, moderate, and severe. Again, review, less than 5 is normal, or is it? If you wake up 4 times an hour and you sleep 8 hours, 32 times a night, does that feel normal? Probably not. Let's make sure we're not dismissing our primary snoring or upper airway resistance patients because they don't have that quote unquote apnea diagnosis. Many of them can still benefit from therapy, but you got to know who you're talking to. On that point, do you know who you're talking to? Maybe how you talk to them. I'm going to give you a couple of things here. No, You don't have to sit crisscross applesauce. It's cool. But I want to do a quick breathing exercise, 2 of them with you really fast. This is challenging because I can't see your faces, so I'm trusting you. But I want you to do this with me. I want you to pinch your nose. I want you to close your mouth and try to take 4 deep breaths, as deep as you can, not getting any air. Feel the vacuum inside. Do this. Now everybody absolutely hates my guts.
That's terrible, man. Why'd you do that?
It's terrible. That's actually part of an ENT consult. And what they're doing is they're simulating apnea. What we just did is we simulated the apneic collapse in your airway. How many of you all felt the tighten right here, like it collapsed right here? I'm going to step back. How many of you all felt pressure right here in that upper esophageal sphincter, where that's the valve that holds your stomach acid in and opens up to let food through, right? Acid reflux, 26% of patients, I believe, have obstructive sleep apnea. There's a huge overlap in that population. So do we know which one comes first? We got to figure out what's going on first. And if the patient has apnea, if they do, let's treat it. The reflux goes away, great. It was secondary, just as a side. But again, something simple. If you want to simulate apnea for your patients in the practice, do that. Not in your hygiene visit. Don't break your work. We're getting a workflow, okay? You're not going to break the schedule. You're not going to try to do this in your hygiene exam because your office managers will try to harm us. We get it. But in a consult setting, in an effort to try to talk through this with your patients, maybe even your sleep champion or sleep queen or whatever that lead role is for sleep in your office, that person needs to really know how to talk to patients, how to get them to understand how this feels, and could they imagine feeling like that when their finger wasn't on their nose, when their mouth wasn't closed, but their body was still doing this. That feels incredibly traumatic right away. We also do that at the end of exhalation, so your oxygen starts to tank because the pool of oxygen is out of our lungs. So knowing a couple of breathing exercises and communicating is a critical component of helping patients understand what's going on. I will tell you this, I've got 4 main secrets I'm going to share with you tonight. A 3-step workflow, 4 workflow secrets. But I'm going to tell you right now, the one thing, if you don't remember anything else tonight, the one thing to remember is that communication, good communication, is the glue that holds everything together in your workflow. You could have pieces and parts fall off the wagon, but if you know how to talk to patients and they are committed and they understand and they are bought in, things might happen. You got to reschedule them. Stuff happens, but you will not lose people. Communication is the common thread that ties everything together. And I'm going to strongly advocate that if you and your team have not gone through any type of communication training or any type of verbiage, role play, supportive stuff, I would strongly encourage it, because it does absolutely make a difference when that handoff is sticky, when everybody knows their piece and they know how to talk about it and the patient is clear on what's happening. It's priceless in the practice. All right, switching gears. Here's the 3-step process. Well, we got to find people first. Actually, let me ask a question here. I told you guys I would. How many of you all, you can answer yes or no to this. How many of you are receiving physician referrals right now? Yes, receiving, no, not. Or hands up and down.
A couple raised hands. Randall
Okay.
Smith, Mark Stallman, Liz Shelton.
Awesome.
A lot of raised hands, yeah.
Cool. Good job, you guys. You're getting physician referrals. That means somebody else is finding these folks for you. That also means somebody else is testing these folks for you. You know what that means? All eyes are on your treatment protocol. Those referral sources are only going to keep sending to you so long as you're treating their patients well, they get good feedback from the patients, and you communicate. Remember, that common thread. Communicate well with those referral sources. That's key, absolutely key. When Todd is working with your practice and you've got an influx of patients coming in from social media, different places, they've never met you. They saw an ad that they responded to. They want to have a conversation over Zoom. How do you build rapport with that patient? How do you build trust with them? Where are they at in this process? Have they never tested before, or do they have a test, they've tried a CPAP and they are dying for something else, right? You got to know, where are they at? But here's your very simplistic 3-step process. We got to find people. We've got to get them tested somehow where they get a diagnosis. And then we got to know what we're treating them with. Are you treating them? Are you recommending something else? And how do we make sure that this is just seamless so there's no cracks in the floor? Well, let's get to it. First thing, if you are screening in your general dentistry practice and you're doing it as the doctor, you're doing it wrong. Docs, you're the ones that go to CE courses. And I truly, truly admire leaders that want to lead by example. And that is awesome. But you should not have to mop the floor every week in your practice, even though you know how to use a mop. This is something that your team has got to be on board with. If you are doing hygiene on your own, your day is totally destroyed. How many of you, raise the hands. If you guys want to put your hands down and then raise them back up real fast for me. How many of you in the recent months have had to work your GP day without an assistant? Yeah. Wasn't that the best day of the week? Like everything just flowed like magic. You just did everything yourself and no, are you kidding? Those are like the worst days ever, right? Because you lean into your team. That assistant knows their role. They have a core function. They're bringing the patient into the room. You hop in, do your doctor only stuff, regardless of what it is in the recare chair. And then they're facilitating the patient going back to the front through checkout, cleaning the room, prepping it, getting things. You've all got different roles. You're not identical. And in screening for sleep, please don't make the mistake that you need to be the one talking to the patient for 10 or 20 minutes in a hygiene consult, because it breaks your crap. And we don't want to do that. We want to actually help people, not hinder our team from doing their job. One of the quickest ways you can turn your team off is not enable them to be part of the workflow and just talk through this and break the rest of the things that they are involved in. Don't do that, please. So do this on a team level. A second component to this is you need to have a protocol. What do I mean by that? Well, there's 3 core components to your screening protocol. One is your health history. You guys probably already know this, but if you don't have questions on your health history that are somewhat related to sleep, not necessarily apnea, but sleep, wellness, do they wake up feeling refreshed? Have they ever had a sleep test or been diagnosed with sleep apnea? Have they had a CPAP? Do they wear it frequently? Have they been affected by the Philips CPAP recall? There you go. There's 5 right there. Those suckers should be on your health history. If they're not, add them or modify them to fit what you want on your health history. I love specifically the verbiage of, do you awaken refreshed, full of energy for the day? Refreshed, full of energy. Because you know what catches people? The patients that circle the first N and write a line down the ends. No, they don't awaken refreshed and full of energy. Whoops, they done messed up, because that's the one you're going to tag on, right? So 5 questions you should add to your health history. You also have a whole gold mine of information looking for these people screening. Did you know that all hypertensive patients are 37% likely to have apnea? 37% of the hypertensive population, according to that study, has apnea. How about diabetes, type 2 diabetes? 72%. That's a couple. How many patients in your practice? Let me have you do this in the chat, if you don't mind. What percentage of patients in your practice are hypertensive, diabetic, or obese? Throw me that in the chat. Any one of those three: high blood pressure, diabetic, overweight. What percentage? Hit me in the chat. I'm going to keep rolling with this so we're on time. I'm guessing it's quite a bit. I'm not seeing anybody in the chat, people.
Not either. I see me.
So we know it works.
It does work. Let's see. Show chat previews.
Did you disable Tony's chat? Or all of them? Well, Tony's chat is disabled. If your all's chat is disabled, my sincere apologies. I'm beating you up for no reason.
That must have been a setting in Zoom that I overlooked. So
no sweat, man. All right. So Liz said 70%. Thank you, Liz. That's a lot of people. What do we do with that? Well, we got to figure out who we're going to talk to, how we're going to do that. That's a team sport, right? One other piece, you might want to have something like this in your practice. Maybe this guy doesn't do it for you. No problem. Switch it out, change it up. Non-verbal things that they can see, minimal touch points in the process of them seeing information about airway, seeing information about apnea, complications. You know that no one in your practice in hygiene is going to get screened for impotence, right? You also know that none of your male patients are going to talk to you about that problem. But if you have something like this, their wife is going to ask you about treating sleep apnea, and that's new. How long have you been doing that? What's that look like? Oh, we start with a consult. Can I get Jim scheduled for that, please? It's going to happen. It happens in the client offices all the time. So having a non-verbal touch point like this is wonderfully helpful. Use this, do something else, totally your call. Find what pieces of their health history are a red flag for airway. One other workflow tip on this before I move on to the intraoral signs. On your health history, if you have digital electronic dental records, Dentrix, EagleSoft, that kind of thing, figure out a way that you can tag patients either on Monday for the week or the night before. This is not you, doctors, your front office people, whoever pulls the charts proverbially digitally the day ahead. If they're reviewing them, if they're making sure everybody is confirmed, whatever the case, you can give them a filter criteria to go through those charts and flag anyone that is high risk for airways simply based on their health history. That's not where you start the conversation, but it's flagging your hygienists and helping your team be more consistent with their screening. Flag them first. If you're still dealing with paper charts, physically have a dot or something that goes on that chart. If you're digital, you got a routing slip, like do you figure out that tiny piece, but flag it ahead to prompt your hygiene team about it. If you do a morning huddle, insert this into your morning huddle conversation. Hygienists are doing roll call. They're going off, hey, I've got 7 patients today, Alex, Bob, and Wilma. All 3 of those, they're high risk for airway. I'm going to have a conversation with them. I'm going to do my intraoral signs and then whatever else they have. That doesn't take long, but it's just rapid fire.
Yeah, I got a question, Michael.
Yeah.
Some of our offices, their staff has been resistant to these additional measures that need to be taken for screening. How can, as a leader, as the doctor in an office, how can you encourage these measures to be adopted by your staff? Because I've heard that, staff can be resistant to change, staff can be resistant to additional things you're asking them to do. What can you do as a leader to kind of move this along?
There is a component of me personally that wants to respond that Home Depot and Lowe's sell these, varying sizes of circular rods. And I'm just kidding, just the poking rod and spanking stick. But, get them going. It's called the job. We all have to work at it. There's a component to your response that's going to need to have something like that is professional and respectful. Yeah. If you are the doctor, you are the leader, you are the business owner. On some level, your team needs to follow your leadership. And this is something we are doing. The we are doing this comes from you as the leader. How you do this needs to come partly from them. And Todd, to answer your question specifically, equipping the team, bringing them into this, take them to a CE course. I mean, guys, I'll show you a slide where you can get a discount from our virtual CE course later. That is not a plug for that. But there are virtual courses, there are online videos, there are live CEs. If you want your team to do this, you cannot go to the CE events. How many hours of CE have you gone to on sleep? Think about that. And you come back in your way, you grasp whatever percentage you do, and you put that into a 20-minute or a 2-hour PowerPoint. So you've digested things and you can't do that.
Yeah.
So get them the tools that they need, the support that they need, lead well, equip them. And then the third component, I think, is accountability. I know that was like total teaching mode voice, Todd. I'm sorry.
No,
Leadership.
it's good because it is something that offices struggle with. Like, I can't get my team, like, I know what we need to do, I just can't get them to do it.
Yeah.
So yeah, it's kind of put the leader hat on, and kind of like Elon Musk saying, no, you will come back to the office to work or you're fired. It's kind of a hard thing to say, but he is the leader of that company.
Right.
So
and
just to let everyone know, chat should be enabled now. So if chat, if you want to try that again, see if people can enter the chat, just type a 1 in there or something just to test it out, and we'll see if it works. If not, hey, there we go.
Yeah, Rebecca, you're first.
I'm a technological savant. I love it.
All right, guys. So let me ask this. Since you can chat now, let's put something in here that's worthwhile. How many of you all have team hindrances right now with implementing this? Okay. Yeah. It's a common thing. Common just means it sucks for more people, to be clear. Like, that shouldn't make us feel better that we're not on an island. It does, but it just sucks for more people. Let me lean into that. This isn't part of the slides, but I'm going to lean into it. Rebecca just hit it on the head. They need training and we need to empower them. So what I just shared with Todd was 3 points. You got to lead well, which means we are doing this, but how do we do this, right? We are doing it. I'm the leader. Then you need to equip the team. So they need to be trained, equipped. What physical tools do they need? Do they need a questionnaire that's laminated that they can write with a dry erase on it? Do they need a custom form that's pre-built into Dentrix because that's how they work? Like, find what your team needs and equip them. And then you probably, if you just ask them, hey, what do you need to do this? They're gonna be like, heck if I know. You went to all the CE courses. I don't know what so training and equipping go hand in hand. The third component, though, is accountability. They've got to have support structure. We are all human. And if we want to create behavior change, we have to do things in repetition, almost always with external accountability. And if you, as the doctor leader, are saying, we're going to do this, I'm going to get you guys trained, and then you're going to tell me what you need, and then we're going to have this accountability. I'm going to hold you accountable. That usually doesn't work very well. For some it does, but that's rare. Todd just said incentives are huge. Abso-stinking-lutely. And we paused on the screening part here, so I'm going to say this. What we have seen work predominantly well in practices, in the screening arena, you have group goals. You have group incentives. How many hygienists do you have? 2, 3? Well, everybody's kind of supporting this whole screening workflow. How do you bonus one person on that? Well, you don't. Hey guys, what do you want? We're going to try to get these HSTs out of our practice. They shouldn't be here overnight. That means they're not working. So that's very low dollars for us, but what's our goal and what would you guys like? Special lunch. Okay, well, maybe that changes when you're delivering appliances and it's a trip to the winery or a trip to the racetrack, right? I mean, common group goals are going to be tremendously helpful as incentives for your team. until you have racehorses that are pulling away from the pack to try to run your program, and everybody else is holding their bonus back. Then they need to be paid. So we can talk more about that. That may be a component of a part 2 of our webinar, because we don't.
Yeah, that's probably a part 2. So
yeah. So getting back into screening, we got health history that will inform us ahead of time, give us some red flags, pre-screen, identify, help hygiene. The intraoral signs is actually how we're going to screen. We want to screen from the mouth out. Does your hygiene team know what to look for? This is a moderately comprehensive list, but it's not everything. Do you have a form that they can pull on, that they can use? Do you have visual aids where they can tell the patient, open your mouth and stick out your tongue? Aha! And they ask that, hey, do you want me to take a picture of this? I'll show you what I'm looking at. This is hygiene, going back and forth. Now, again, your hygienists are busy. They can't just have a 40-minute dialogue with the patient, but they can absolutely redirect some of their conversation towards this. And how much the patient responds is how much they should lean into it. But again, visual tools supporting mechanisms. The last piece is symptoms, or what I would call emotional pain. This right here is the money. Every single human on this planet makes decisions emotionally. The higher the dollar, the higher the emotion, the higher the level of imputed or unearned trust they put in the company or the people they are buying from. Because when we want something, we mentally, logically justify why we want it. Well, that makes total sense because, okay, whether it does or not, I got to tell you, if you guys can uncover the patient's emotional pain points in this visit, it will exponentially increase your case acceptance for treatment, because you know what motivates them. They kind of could probably care less that they've been mildly to moderately overweight most of their life. They got high blood pressure a little earlier than the rest of their family. And, you know, everybody's pre-diabetic in my family. It kind of sucks, but you know, it happens to all of us in this crew. So that's not a motivator, guys. And you all know when people crack their teeth in half and you take a picture and you're like, that's the size of Florida, right in the middle of like number 14. And they're like, it doesn't hurt. Find what hurts, because this will motivate them through the process.
We had one of the offices we worked with in Maryland. They had a sleep coordinator. She's in sleep for 30 years, had a Southern accent, just like the grandma you really wanted in your life. And the question she would start off when people would kind of flutter and kind of shaky on their decision whether they're going to move forward, she would ask them just straight. She's like, sweetheart, who's going to miss you most when you die? And I was like, Risa, you can't say that to people. And she's like, oh yes, I can, Todd. I love them.
Right.
But that, like, people aren't considering that in a consultation. Like, who is going to, like, am I going to be able to walk my daughter down the aisle? Maybe not.
Right. Yeah.
That's scary for me.
Yeah. And it's hard because we want to say, oh, that's the money, that's the juice. This is what we want to hone it. No, guys, listen, you could take every negotiation and communication persuasion course available to you, read every book under the sun. You're not manipulating people. If you're a doctor who helps convince patients to do the next step because it is clinically appropriate, that's called your job.
Yeah.
And doing it well.
Sales in dental sleep medicine, sales skills are your moral obligation. I did a YouTube short video about this. It is a moral obligation that you have to your community and your patients to be good at sales. Yeah.
So on that note, I'm going to show you this quick video about motivation and what not to do.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
No, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
That sounds really hard.
It is. Thank you. Ow!
Come on. If you would just...
Don't.
Try to see things
All right, so that's absolutely not a male-female thing. This is we don't recognize a lot of times what the core issue is. And we show that video all the time when we train teams how to screen. And it's hilarious, the responses, because the true thing here, getting back to emotional pain points, it is not about the nail. It's actually not about apnea, because they are not waking up, choking, gasping, terrified because they had the 273rd dream that they drowned to death. If you have a patient like that, they have absolutely no resistance. They want whatever you have because they got to fix this thing, right? That matters. But again, it's not about the nail. It's not about apnea. One other verbiage nugget that I will give you all: don't use sleep apnea unless it's absolutely necessary in your screening conversation. Use airway health. It sounds like we're splitting hairs, and we're not, because guess what? When you're screening people that haven't been tested, they know they don't have sleep apnea. Just ask them. Have they had a test? No, but they know they don't have it. So don't fight the natural opposition people have. You have to be diagnosed with it to have it. So everybody has an airway. Everybody wants to be healthy. Use airway health instead of sleep apnea or obstructive sleep apnea. Second workflow secret here: testing drives treatment. Well, first off, I'm going to give you two questions. You need to know what you're testing for. There are over 90, almost 100 diagnosable sleep disorders. That's a lot. If you're testing for something neurologic and etiology and you don't have a test that tests their neurology while they are sleeping at night, meaning EEG wires on their head, you're doing the wrong test. The cool thing is, home sleep testing and obstructive sleep apnea and dental scope of practice, they all perfectly align. In a dental office, you can treat for snoring and upper airway resistance, obstructive sleep apnea, and sleep bruxism. You don't need a test for sleep bruxism. You're already doing it with night guards. But those other two perfectly align with an HST. First, know what you're testing for. That's question number one. Question number two, what test would they like? Which one will they actually do? You might have a fantastic relationship with your local sleep doc. If you do, I applaud you. Most don't. But if you do, and you try to send everybody to the in-lab test, and there is no way on earth they're going, that's the wrong fit for them. Find another solution. If your sleep doc has home sleep tests, guarantee they do. Talk to them about it and know which patients are going to get an HST. Almost all of them typically, but most patients don't know that, so they won't go. Is it helpful for you to have an HST in your office? Absolutely. If you're in a state where you are legally allowed to own them, that's crucial. It is absolutely helpful for you to integrate HSTs into your workflow. Now, that being said, this is a workflow talk. How would we do that? I am glad you asked. Well, we got to hand out the home sleep test. And I'm going to give you a couple of things to do when you do that. If you own a test and you are handing it out to your patient in your dental office, number one, you're going to reappoint the patient for their consult a week later. Tuesday to Tuesday, Wednesday to Wednesday. Pick your date. Give it a week. Reappoint your patient for a week out. Second thing, they need to sign a checkout form of some kind. We call it an Hst checkout form. You can call it whatever you want. That patient needs to sign that they have a $25 per day late fee and a $4,000 or whatever your test is repayment fee. If they break it, take a bath with it or sell it in Tijuana, right? If they don't bring it back, they owe you this. If they bring it back a month late, they owe you something else. But their signature and their credit card is on that form. That's number two. When they bring it back, who does what with it? The patient isn't reappointed for a week, right? So your front office people need to know when that patient's unit comes back, who intakes it. Someone has to clean it first, throw away the disposables, wipe down the unit, plug it in the computer, get the data off of it, and then upload it to the portal. We have a cloud. Some softwares have a cloud. You can have an interpreting physician read that test data and get it back to you in our service within 72 hours. Some is a little bit longer, but you can have a service connected to your HST, and that patient can come back in a week's time with an interpreted report with recommendations. What needs to be on the report? Well, there's 4 things that you have to have on every single sleep report, no matter where it comes from. Number 1, it has to be recent. If you handed it out, that's a default. If somebody brings you their test report, make sure it is within 1 to 2 years and no health history changes. They didn't gain 15 pounds or lose 15 pounds. They didn't have head trauma, like no health changes, 1 to 2 years old. It needs a diagnosis of obstructive sleep apnea, mild, moderate to severe if you're treating OSA. It needs the physician's recommendation of your treatment, meaning oral appliance, MAD, MRD, whatever they say, oral splint by a dental professional, it's got to say your stuff. If it doesn't, and you do it, you're going against medical advice. Don't do that. The last thing is it's got to have a signature. You would be shocked at how many reports come from specifically hospitals that don't have signatures on them. That's a draft report. Recent diagnosis, recommendation, and a signature. Got to have all 4 of those in order to move forward. Once you do, now you've got the patient screened, they've been tested in whatever medium, you've got a report that meets criteria. Now we've got to do the clinical treatment plan and the financial treatment plan. I'm going to tell you, workflow secret number 3, you sell downhill. Don't fight gravity, sell downhill. What do I mean by that? Well, go through risks, benefits, and alternatives for each treatment option. Each patient has the option to do surgery. Go get a CPAP. Maybe they already had one if they're referred to you by an MD. They have an option to do an oral appliance, and they have an option to do nothing. All of those affect their lifestyle. But let me tell you, if you will talk to people about doing nothing, you get to dictate what it costs them. Everybody knows this is an option every time you recommend something. You know why? How many of you have had a patient that says, I'll think about it? You get done with your spiel, like, da, 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 apnea. And they're like, I don't think about it. No, they're not. That's just a non-confrontational way of saying no. If someone says, I'm so glad you went over this with me, I knew something was going on, I need to talk to my husband because we don't make these kind of financial decisions apart, but let me talk to him. I'll call you by Tuesday at 2 o'clock in the afternoon. We should be able to talk by then. That person's thinking about it. Intent, time, measured. If they don't, they're not. So what are we looking at with oral appliances? Well, you guys know you've got to screen TMD, make sure they don't have severe TMD. I'm not even going to step into the weeds on this. Do your normal clinical exam, make sure they're a proper candidate, mild to moderate first-line treatment, severe if they've already failed CPAP. You guys know the deal, right? It's pulling the jaw forward. Workflow item. Do not ever treat a patient and not have an efficacy test. Hound them for this. And if you don't have one of these, you absolutely need an against medical advice release letter that the patient has signed saying that they absolutely unequivocally will not follow your advice to do a follow-up test. Guys, I'm telling you right now, you do not want to be the provider on record treating a patient for a potentially life-threatening disease that helps them fall asleep at inopportune times during the day, like when they're behind the wheel. You're the treating provider with no objective evidence that your therapy works for that patient. That's not good. Make sure this is there. If you own a test, use it. If you don't own a test, refer them back, follow up with them, and have that documented that you have referred them for that test. You've referred them for that test. You need that data or a signature on a AMA form that says they're not going to do it. Please make sure you do that. All right, I told you we need to define what doing nothing costs. Well, if you don't manage their mouth well, or they don't manage their mouth well, I should say, their teeth die. And no disrespect to the dental profession, but there are plenty of patients that are edentulous in the world, and they're okay. They eat different, they smile different, they look different. Maybe they don't live as long, but they live. There's not a single person out there that lives without an airway. So is this more important? It's more critical. So when you're talking to somebody that has severe obstructive sleep apnea and they're telling you square to your face, I'm not using that dang CPAP blower. My family's had that and I'm not going to look like an elephant. Okay. But you know, most people with your level of apnea die 7 to 10 years younger. You have a 500% faster cancer growth rate, and you have multiple X risk for stroke and heart disease, kind of all the things that people die from. But you know what? Stroke, it probably won't kill you. You'll just be disabled for the last 20 years of your life. You sure you want to do that? You don't have to be sharp for most people. But I'm going to tell you, if you put doing nothing on the table, you can define it. So when I said sell downhill, what I'm talking about is talk about the surgeries. People hear about Inspire on the radio. That's the implanted pacemaker device where they run outpatient. They run a wire up your neck with 3 electrodes that attaches to your right hypoglossal nerve, and it shoves your tongue forward, up, sideways, whatever, in order to shock your tongue to go out of the way every time you take a breath. It's effective in a percentage of the population. Cool. Are people going to start there? No. They can't have an MRI. They can't take it out. I mean, there's like big things with. Here's my point. If that's your last resort, you are stoked that that surgery exists. I'm very thankful that that surgery exists today, because there's a subset of people that desperately need it. You know what? Your oral appliance candidates are not even thinking about that surgery. So surgeries, CPAP, everybody knows about this and they hate it. It's not sexy. Nobody wants it. Everybody fails it. It's got all the stereotypes. So surgery is up here. CPAP is up here. You know what's below that? Oral appliance. So if all things are equal financially and you go surgery, CPAP, oral appliance, which one do your patients naturally gravitate towards? Oral appliance. If it's clinically appropriate and an option based on the sleep physician recommendation, you're always operating under that recommendation. That's point critical. But when you do, what are you recommending to the patient? What's the first commitment that you want to get from them? My argument would be that you actually want to get them to commit to doing something, not nothing. So take doing nothing off the table, and that's what's going to be the game changer for you. So, I knew that was going to happen to me. I was like, my slides are not responding. Take doing nothing off the table, recommend they move forward with something. If it's CPAP, refer them out, you're their advocate. We can connect you to a company that does CPAP, so we don't make a dime. I'm happy to connect you. If it's surgery, okay, great. The person you should refer them to is the ENT, because predominantly that doctor does almost all of the sleep apnea surgeries for patients. You don't want to do an appliance, no problem. I want your commitment, you're going to do something. Like Todd's doctor, the Southern accent, said, hey, who's going to miss you the most when you die? Maybe you can't pull that off. You don't have that sweet Southern charm. Totally understand. People would punch me in the face if I said that. But hey, do you get them to do something? That is the main take home. Do something. The last piece, payments make profits. I really don't care if you do medical billing, if you bill out of network, if you're doing a hybrid model where they pay you up front and then you submit the claim, or you're doing straight fee for service. You know what sucks for patients? When they get sold something or asked to pay for something in a way that doesn't make sense to their brain. We pay for tanks of gas by the gallon, and we know the price per gallon. When you walk onto a car lot, think about it. The last time you went and bought a car, the first question is, what car are you looking at? Oh, I want the SUV. Okay. What monthly payment are you looking for? They don't ask you how much money you have in your bank account or how much money you want to spend on a car. They ask you what your monthly payment is. So that way they know what they can and can't sell you. Because there's all kinds of different levers they're going to pull. Just ask them. You don't have to go to a car lot to figure that out. But I'm telling you, having a document that allows you to clearly communicate the total value of your treatment and then your payment options is absolutely critical. Now, this one here that you're looking at is geared towards a fee-for-service patient. So if we break it down into its two parts, the top part, everything that's in the treatment, bullet points. I actually had the privilege of writing an article for Dental Sleep Practice a while back, and I broke this down in great detail. If you're the front office person or the treatment coordinator in your practice, doctors, you shouldn't be doing this. But your treatment coordinator has this form, they're facing the patient. They should have a pen or something they're pointing with and touch and explain every single one of these bullet points on the list and how valuable it is and what you're doing and what that means for them. This is your total airway package. We are going to do this, doctor's going to do this. This is how it works. You get your appliance, we adjust it. It's custom fit to only your mouth, your teeth, comfortable. We adjust it for your fit. Then we're going to type, you're building the value. Does all of this stuff matter? Yeah. Does it have any value? Not by itself. This is my argument here. So much of the time, we try to, now this is the selling conversation, treatment coordinator, not doctor. This is selling. This is getting the patient to figure out how to pay for the thing that they're supposed to do. This is selling. So much of the time in the selling conversation, we focus on the thing and building value in the thing. And I'm going to tell you, the absolute most compelling conversations, the highest conversion for sales is when the solution or the outcome is what's focused on. I have a couple of minutes and I'm going to take them right now because this is probably going to be a game changer for you guys that are quoting treatment. I hope, I'll say that. When you connect to people and you understand their emotional pain point, remember all the way back, we got health history, intraoral signs, emotional pain. Emotional pain is the motivator. If you have a patient that is waking up 50% of their days with a headache in the morning, half of the week, every week, they wake up in physical pain, like a bomb went off. They have a hard time focusing. They have to start their day. And then part of the way through their day, they're exhausted. They feel tired driving home from work, like they could fall asleep at a red light. They're just spent. And they're so sick and tired of feeling like crap, feeling like they can't get it together, like everyone gets to operate at a different speed and they're just stuck. Does that have anything to do with their weight or their blood pressure or anything on their medical document? Absolutely not. Hey, you know what? How would it feel if you woke up without pain? When's the last time you woke up without pain? Not kinda, not lingering, any pain at all. No pain. How would you feel in the morning? Oh my gosh, it would feel so good. I could probably focus. Awesome. When you felt focused, you felt in the moment, you woke up refreshed, full of energy for your day, no pain. How would you feel when you went to work? If it was a Saturday, what would you do on that Saturday? What would be different for you? Oh my gosh, we've had people that grandma says, I pick my grandkids up from school and I can't take them to ice cream because I'm too scared to death. I'm going to fall asleep behind the wheel. I got to go straight home. I take my grandkids to the park. We'd go take the dog to the dog park and throw the ball and have an absolute blast. That's what we do. You know what? I want to help get you there. I'm not making promises that I can't keep. You're waking up 14 times an hour. The sleep physician said that this is the recommended treatment. I will help you do whatever you need. I'm just asking that you don't do nothing. But now that you've committed to that, here's my commitment to you. We're going to go the distance. I'm going to walk this path with you. Here's the treatment option. Here's everything that we're going to do. But you know what? For the 2 years that you're under our care for this, we're going to manage this thing together. Every step of the way, that's what we're going to do together. You go talk to Marcy. She's going to help you out. You can figure out all the financial arrangements with her. Guys, a $3,500 treatment plan, fee for service. Okay. Don't use 3,500 because I said it. That's not my point. 3,500 is a round number. It's kind of in the middle of the fee for service fees that we see being billed across the country. $3,500 at 24 months on care credit. Yep. You got a 17% ding. That means you're going to keep just a little over $3,000 on that case. If that doesn't work, raise the fee. You know what that is to the patient? $147.52 a month. $147.50, pardon me. $147 a month is less than a Starbucks cup of coffee a day. You're going to feel better. We're going to help you not wake up in the pain that you've had. Your airway is going to be open. Again, don't make promises you can't keep, but you're going to be their advocate, deliver the care that the doctor recommended, and you're going to help them overcome this thing. So help you God, because that's your role here. Your patients will love you for this because you're going the distance. I told you in the very beginning, communication, even though this is workflow, nuts and bolts, what do you do? What do you do? Communication and the way you level up that communication is going to be absolutely critical in leveling up your sleep practice. It is one of the key differentiators. Todd, I see something in the chat that you commented on. You want to share that with the group?
Yeah, Dr. Mostatab was saying she had a patient cry when they told him that this could be what he was suffering from and no one else could diagnose it until now, essentially. And she was just saying it's a blessing to be able to do that. So
yeah, that's awesome. That's awesome, Doc. Cool. Thank you for sharing that. Those are the wins. But you know, just so we're on the same page, you know, I think everybody here has experienced some of this because you're here. But there's going to be rejection in the when you open this up. You're opening a can of worms. They didn't ask you about this. You start asking them. You're going to get shut down by some people. I mean, they're a walking zombie, but they sleep fine. And they just had apnea in your chair because you laid them back. Like that's a big deal. But you're going to have some wins along with that. Don't let the rough spots and the hard conversations deter you, whether it's from your team or it's from your patients. The outcome is worth it. Stay the course. That's my oh, there you go. Stay the course.
I love it. No, we'll definitely let's open up the Q&A time. If you guys have questions for Michael, go ahead and post them in the chat, or actually, as Michael requested, post it in the Q&A section. That way we can keep everything organized. And you know, I have a question to start it off, Michael, if you're okay with that, while we wait for anybody else's questions to come through.
Mm-hmm.
Case presentation is I mean, it's obviously critical. You know, screening, testing, huge aspects of an efficient sleep workflow. But the actual case presentation, do you have any pointers and tips of the conditions in which you present? So you don't do you want the patient laying back in the chair while you're making this presentation, or do you want them in a separate room? Like, what are the conditions that create an atmosphere for them to okay, now we're getting serious. We're having a serious conversation. So that
Yeah.
they really start thinking about it. Do you have any tips for how to create that atmosphere?
I do, yeah. And that's a great like launch pad too, if we don't have other questions that are coming in. So first off, laying back. If they are laying back in the chair, please, I would strongly encourage you, don't ever have any aspect of a meaningful conversation with them in that position. That's the same position that every animal does that's submitting to other animals so they don't die. Please don't tear my guts out. I'm defenseless.
Yeah.
That's not the position you want your patients in. Eye to eye, knee to knee. If you're sitting down, you're in the chair for hygiene visits. This is the challenge, because you'll run in and you'll see somebody that you've known for 15 years and you basically high five them. You start talking at them from behind. Like if I'm the dentist and Tony's the patient, well, let's switch that. Tony's the dentist because the actual dentist, I'm the patient. He walks in, man, I'm poking fun at him before I can even see his face. That's a different relationship, right?
Yeah.
But if he comes in and talks to me, he's not going to start screening me for some health issue without sitting me up and talking to me eye to eye. When he's serious, we're chilling, I'm laid back. If he's serious, I'm sitting up. That's only for screening. But post screening, once you have a test report, I would absolutely have a dedicated space. If you have the consult room, that's where it belongs.
Okay.
You have a mannequin head with a CPAP mask, not to scare the junk out of them, because you could, but you can show them, hey, this is what CPAP is if you've never heard about it. By the way, there's other surgeries. They can implant a pacemaker. They can do all this stuff. I can refer you to an ENT. Boom, surgeries, CPAP. Here's some sample appliances. You guys see the samples on my shelf right here. Picking a sample up and saying, hey, this is how it works in your mouth. Feel this. This is durable. It's custom fit to your mouth. This is how we make it, and this is how it adjusts. Like those things, eye to eye, knee to knee, talk to them with respect. You do already. Translate the things to them so it makes sense. And I would actually say even further, turn the clinical pieces, the sleep study report review, the treatment options that you're talking to them about, translate this into the words that they understand, not the clinical words that are right or appropriate. You don't have to be clinically inaccurate to dumb it down to where anybody can understand it. That's kind of your job.
So instead of saying like titration, you're saying adjustments.
Yeah.
Yeah.
We're going to make this fit your mouth. Every single tooth is accounted for in this mouthpiece. Do you see it? I know you gag, Margie. Look at the inside of this appliance. See how it fits on here? Look underneath. There's no material on the inside that your tongue would touch. It's only on the outsides. This is why this is going to work for you. Translate it to them. And we're getting heavy in the verbiage stuff, but mirroring their emotions, body language mirroring, repeat some of the words that they've shared with you so they immediately intrinsically feel heard, trust building, and then point them to the direction and ask them questions that lead them that direction. That's what you're doing. That is going to be incredibly helpful in your treatment planning.
Awesome. Dr. Mostatab asked, do you show videos? I'm assuming that means during case presentation.
That is going to be provider specific, Doc. You can. The only hesitation I have with that is this is your time. I would strongly recommend that you can have videos or a PowerPoint presentation, something on an iPad or even a screen, if you have your sleep champion doing it. So if your doctor time is not tied up with it, you don't want to sit there while they watch a 3-minute video. You could have done a hygiene check on an existing patient that needs nothing, right? So we want to bake in efficiency. When you have a dedicated person that can step into more of those roles, again, lifting your entire team up, that rising tide is going to raise all ships. Raising up a sleep champion that does the HST report review better than you do and talks to the patient about treatment options. And then you come in as the doctor expert to ask them if they have any questions. No, Did Summer talk to you about surgeries and CPAPs? Yep, she did. I do not want that. Talk to me about the appliance. Awesome. You know what? This is what I do. You're the doctor. Own it. This is what I'm going to do. We're going to do this. I'm going to make a device. I'm going to evaluate your case. We're going to take impressions, do this thing. This is how it's going to work in your mouth. I'm so glad that you're going to do something. High five, because you matter. That is ideal. So in that scenario, yeah, you could absolutely have your sleep champion show a video that's honed in. I wouldn't do it other than in that scenario.
Awesome. A couple questions in the Q&A. We got a well done, Michael. Then Tony asks, is it possible to get a copy of your liability release if they refuse to follow your recommendation or get tested, or just a quick outline of a few things they need to compose? So yeah, Tony, you're booger. You know this. We have a huge library of forms in our online platform that's available for purchase, monthly, annual, lifetime. Like, there's a lot of options. But yes, we have the form. It is for purchase. Let me just give you what needs to be on it. This is what's recommended. I insert patient name. Do here. I'm just kidding. I'm not an attorney. I am not going to do X, whatever the blank is, recommended treatment, insert recommended treatment. I am aware that patients who have obstructive sleep apnea and are not treated have a higher risk of, and you start listing the increased cancer growth rate. You list the increased risk of stroke, cardiac arrest at night, all of that stuff that we've already talked through in the studies. You just start listing all of this stuff. And that's your AMA form for not accepting treatment or not doing anything for treatment. You do almost the same thing for efficacy testing, but instead they're treated and you need to verify it. So it's same, insert patient name, insert the treatment, and then the explanation beyond it is, per the AASM's guidelines, an efficacy test is required in these scenarios for this purpose. Going against this is considered against medical advice. I release the Office of Liability, da 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 da. So it's very similar to your other release of liability forms. You would tweak it slightly depending on the use case in what you're doing for dental sleep. Yeah, and we got one more question for Dr. Mosatab. Before we ask her question that's in the chat, I'm going to let everybody know that we do have a part 2 of this webinar series that's going to be happening on August 10th.
Yep.
And it'll be at the same time, 8 p.m. Eastern time. If you guys would, I want you, if you have questions about case presentation or sales skills specifically, like, hey, I feel really awkward about pushing patients or you know, trying to deal, or if you've encountered certain objections with finances, you know, post those in the chat. That will help Michael and I prepare better or give you guys even more value in that upcoming webinar, August 10th. So yeah, post those, and definitely we'll be sure and provide huge value on that next one, because
yep,
communication and case acceptance, I mean, like you briefly touched on it tonight, but you know, revealing that emotional pain, but and uncovering that is essential. And I imagine on our next webinar, we're going to be talking about a process to do that.
yeah.
But obviously everyone has their own practice, their own hurdles or own self struggles as it pertains to case presentation that come up. So go ahead, post those in the chat or in the Q&A, and we'll be sure and make sure those answers, we can briefly touch on them tonight, or you know, we'll touch on it August 10th. And let's see, and we do have a course coupon for you guys through DSP.
Oh, that's right.
If you want to show that, Michael, oh, there it is on the screen. Perfect.
Yep.
So yeah, definitely. Could you describe what this package is, and obviously by being on Dental Sleep Profits list, you know, Michael is graciously giving you guys a discount because you're affiliated with Dental Sleep Profits. So can you describe what this offer is, Michael?
Yeah, absolutely. So we do courses, weekend courses, Friday, Saturday, just like you're used to flying to, except we do it on Zoom Different than the webinar tonight, it's a video call where everybody has a camera and a mic, and we have an interactive live virtual course that's 2 days, Friday, Saturday. We're going to go through soup to nuts workflow, integrate communication, kind of like what I did tonight, very practical, very tangible recommendations, but we're going to weave in all the communication stuff, if you will, into that course so you can walk out with an action plan. If you've implemented and you're trying to level up, you'll get that. If you're just starting out, you're going to get a lot from that course, and you may want to take a clinical course that's a dedicated day of just the nuts and bolts of clinical hands-on with an instructor, doctor and assistant only. This course right here, the 2 days, you guys get $200 off. Doctor, you pay for your ticket. Up to 14 members come for free. So we're talking 70 CEs for $600. And if you guys like tonight, you'll love this because it's not just me on this course. If you didn't like anything and my voice makes the hair on the back of your neck pop, please don't come. We totally understand. There's a lot of great instructors out there, but this is our best effort to help folks get to where they want to go. And we over deliver on this because our 2-day course is our interview for our coaching packages and stuff that we do. So if you can learn from the course and go do it, man, we are high-fiving you the whole way. Lots of people want some support for a short time, and we can offer that too. But that's what the course is. 70 CEs, up to 5 people, 1 doctor, 4 team. That's the link. I think Chad is going to post the coupon code, or it's automatically discounted. I can't remember. It might be automatically discounted. The other thing, guys, if you have questions that are specific, that are not like, oh, I need a general course, you can ask us for free. You can hop on our website or use this QR code. You can click talk to a coach, and it will grab one of our coaching staff, myself or our coaches included. We're here to serve you guys. We'll give you 25 minutes of time for free just to answer some questions. So we truly want you to do more work. That's the goal. Help more people do more work.
A lot of lives at stake. So yeah, I appreciate you guys coming on, sharing your knowledge with the Dental Sleep Profits community. And, I took away a ton from that. I'm super looking forward to hearing about the people who are going to be taking that course. I just saw Rebecca said she's going to do the course. So really excited to hear how that goes for them and hear them implement all the awesome stuff that you taught, and obviously implement what they're going to learn during that course. And don't forget, guys, August 10th, of course, you're going to be getting email updates from me, but that is going to be a webinar you do not want to miss. That case presentation and communication is your moneymaker. Your patient does not care whether you use Prosomnus or SomnoMed or a TAP device or a Herbst device. They don't care. What they care about is whether you care about them, and those little minute details, the emotional side of things. And that's what we're going to be covering. That's my wheelhouse and what I get excited about, because I love communication and really helping people feel like they've gotten value. Hopefully you guys have gotten that tonight. You feel like you've gotten some value from this. I know I did, Michael. So thank you very much. Some lingering things here. It's a great course. Tony says it's a great course. Highly recommend. Awesome. You guys got a little testimonial there. And he said, Chad actually said the link in the chat for the course is actually automatically discounted for attending this webinar until Friday at midnight. So
awesome.
Yeah, definitely.
I was supposed to know that. Thanks,
That's
Chad.
how I feel. That's how I feel with my team. My team is on top of it, and I'm just sitting here like, you know what? I'm surrounded by wonderful people. So, yeah. Again, Michael, thank you so much for coming on tonight. I will post this video, the recorded version of this, on the Dental Sleep Profits YouTube channel, and we will also be sending out a link that has the video embedded on a page where you can reach out to either Michael or Chad if you have any questions. So we'll be sending that out by the end of the week. So look for that if you missed the video tonight. Well, you didn't just hear me say that. So if you want to send it to someone else and say, hey, these guys did awesome, that's appreciated. So
yeah.
I think I speak for Michael. We love you guys. We appreciate you. Anything you want to say, Michael?
I would just say this is a more unique webinar audience. We do big webinars that are very generalized audiences. You guys are more of a tight knit group. I would strongly encourage you, send your questions to Todd. We will, we've got the deck and the content, but we will morph and accommodate those questions in the next presentation. If you guys will send those to him, he will get them to us, and we'll serve your specific community in answering those questions that you guys have. So
Awesome.
If you don't have them and your treatment coordinator is selling the cases, please ask your people and get them to give the questions to Todd.
Yeah.
Yeah, that would be a great webinar to invite them to. If you've got a treatment coordinator that's selling cases, bring them to the next one.
Yeah, definitely. When I send out the registration link for the August 10th part 2 webinar series of this with Awaken2Sleep, definitely forward it to your team members. And it's important. And in my opinion, every single team member should be on that call, because there is a different level of communication that every team member needs to understand. Like you talked about, Michael, everyone plays a part. Every single one of them, from the moment the person arrives in the office, the atmosphere that's generated through that first line of communication to the back office, like your sterile tech walks in while you're giving your case presentation. What do they say? Everybody should know their part. And yeah, August 10th, it's going to be an awesome webinar. So I'm looking forward to it.
Yeah, me too, man. Thanks again for tonight.
Thank
Go
you,
do good
guys.
work, folks. You got it.
Take care, everyone. Have a wonderful night.